Hello, this is Dr. Wells with Wells Medicine, and I wanted to talk about IV catheters today. So, this sounds like a very boring topic, but uh, a lot of patients have questions about the difference between IV, IM, and they, particularly my more needle phobic patients, get very concerned about the idea of having an IV catheter in place for the infusion. So when we do ketamine, ketamine is a very interesting medication because it can be taken orally, it can be sprayed up your nose, it can be rubbed on the skin, it can be infused through an IV catheter, it can be given as an intramuscular injection. There's research being done on subcutaneous injections. I've had pain patients who received rectal suppositories of ketamine and intravaginal suppositories of ketamine. So ketamine is an interesting drug in that it can be used in lots of different ways, and each of those ways have side effects and benefits. So reasons to choose that method. At Wells Medicine, we use IV ketamine and intramuscular ketamine primarily, and the studies on ketamine were pretty much only done in IV ketamine over a 40-minute infusion. And there's a very good reason for that. And it's because when you do intravenous ketamine through an IV infusion, you are receiving 100% of the ketamine that you're given. So 100% of whatever milligrams are in the syringe are bioavailable. So it's very easy to have a predictable bioavailability, which is not the case for intranasal or oral. Generally, there's somewhere between 16 to 25% bioavailability when it's intranasal or oral. And by oral, I mean by mouth. That's a pretty wide range of dosing. And a lot of our patients find a great difference between 40 and 45 milligrams or 50 and 55 milligrams. So to have a spread of 16 to 25% absorbed can be too much for their comfort and predictability of effect when you're talking about oral or intranasal. So when you're giving something IV, 100% is bioavailable, and it's a very slow, predictable curve of the infusion so that you kind of know what the patient is receiving and how that's going to affect the patient over time versus something like oral or intranasal where you're really not sure when exactly the peak of absorption is going to hit, and you're really not sure how over time it's going to be absorbed. So the curves there are very unpredictable. You can have patients that have very, very vivid, intense experiences at the beginning that's much more intense than they would have preferred, and then it tapers very quickly, or you can have a second peak. So maybe you've let them go to their car or to their home, and then they have a second absorption peak because it's hit their stomach or it's hit their small intestine, and now they're absorbing another peak of the ketamine. So oral and intranasal can be very unpredictable absorption peaks versus an IV absorption, which is dripped in at a very predictable slow rate. So that's why all the studies were on IV infusions. We do some intramuscular injections because, again, almost 98% is bioavailable. So you have more of a predictable bioavailability, although with intramuscular, there can be some pretty wildly varying absorption peaks because people have different blood flows to their muscles. So some people absorb it a little faster than others. Sometimes there is more fatty tissue in the muscle, which can change the absorption if you accidentally have, a more marbled tissue, sort of like marbling in a steak. It's the same idea. So if you put it into the fattier part of the muscle, that can have a slower absorption. but the IV and the intramuscular are the two types of injections that we do for ketamine at Wells Medicine. And a lot of patients prefer the intramuscular because the idea of having something sort of under their skin during the whole infusion is very bothersome to them. But actually, the needle size that we use for intramuscular and IV is basically the same. It's just with the venous infusion, we leave a tiny, very thin catheter. And so I did want to talk about that today. When we're doing IV catheters, our smallest size catheter for neonatal infants and very, very tiny vessels is called a 24 gauge catheter, and it's the smallest one that they sell. And we only use 24 gauge catheters. But we give a very small amount of fluid over 40 minutes, so we don't really need to have large IV access for this procedure. So we use a very tiny catheter. When people have intramuscular injections of things like the flu shot or a vaccine or a ketamine, we generally tend to use either a 25 or 27 gauge IM needle. So it's not very different between the needle size that we use for IM and the stick that we do for IV. When we do intramuscular ketamine, we actually break it up into two different doses to try to elongate the curve a little bit and reduce the peak of absorption to make it a more comfortable experience for patients. So if I was going to give 60 milligrams to a patient IV over 40 minutes and I was translating that into an intramuscular injection, I would most likely do 40 and then 20 about 15 minutes apart. So two separate pokes, two separate injections, 15 to 20 minutes apart, to elongate the infusion experience and to reduce the overall peak of the experience so that it's more comfortable. But one of the things that, and I'm getting to the long part of the story, one of the things that I wanted to talk about is the beauty of an IV catheter is that we have access to give the patient medications if they need them. So with intramuscular, we don't really have access to give patients really potent anti-nausea medicine the way we do if we have venous access. We don't have access to give the patient antihypertensive or blood pressure medications. Now we can give oral anti-nausea and oral antihypertensive medications, but those take about 15 to 20 minutes to work versus the medications that we give for blood pressure or for nausea during an infusion when we have an IV. Those take between 1 to 5 minutes to work. So we can get patients comfortable a little bit faster with the IV. And if we were doing an intramuscular injection, those medicines just take almost as long as the experience itself to start working. So it can be a little bit of a mismatch of the medications for the side effects of the injection and the experience of the injection itself. So what I wanted to talk about with IVs is a lot of patients have never seen an IV before. And so the idea is we're trying to put a little tiny hose or a little tiny tube that is a two-way tube into a vein. We try to find a vein, and then we put this little tiny thin tube in the vein. And if it's a really great IV, you should be able to get blood flow back and put medicines in. So it's a two-way tube. Sometimes patients will notice that there's a little bit of blood in the catheter, but again, that just means it's a really good vein and the two-way tube is open. That's what we want it to be. We want it to be open so we can give medications. So the little tiny tube is kind of like a splinter. So it allows us to hold the vein open to drip medication in during the procedure. And then when the procedure is done, we take the little tube back out and put a Band-Aid on and hold pressure for a minute. But I wanted to show everyone what an IV catheter actually looks like. because I think it's really interesting to have a visual of what the IV catheter looks like. So this is a typical IV starting needle set. And so if you can kind of see this, we use this, and see it's very, very tiny. We use this to start the IV. And then after we poke a little tiny hole in the skin with this needle at the very, very tip of it, we slide off the tube, and that sits in the patient like that. And then the tube is inside the vein, and you can kind of see I can play with that and touch that. It's not sharp at all, and it's made out of plastic that becomes at body temperature very soft and fluid and jelly-like. So a lot of patients, when they have an IV in their hand, they get very worried about bending their hand, or if the IV is in their arm, they'll get very worried about bending their arm because they're worried that the needle might still be in there, and that they would hurt themselves with the needle. But again, the needle actually comes out, and we use safety needles because I don't want myself or the staff to accidentally poke themselves with the needle. So we use safety needles, and when you press this little button, the needle retracts back into the body of the needle starting set. So there actually isn't a needle in patients during their infusion at all. It's just this really soft little jelly catheter. And that, when it comes out, leaves this little tiny hole that we just put a Band-Aid on. And the little tiny hole in the skin and the vein heals up over the course of about 3 to 5 days. The reason that you have to put pressure on it is because until the platelets kind of catch up, that can leak a little bit of blood under the skin and form a bruise. And if you put a little pressure on it, give those platelets a chance to catch up, usually we can avoid a bruise in people who aren't on blood thinners like Coumadin, warfarin, aspirin, and if you are doing an infusion set several times over the course of 2 to 4 weeks, it's pretty bad form to leave bruises all the time in patients. And a lot of patients will say, oh, well, when they did my hand at the hospital or when I gave blood, they left this huge bruise on me. And it's usually because nobody told them to just hold pressure for a minute. And nobody kind of put a little pressure dressing on there and allowed the platelets to catch up and seal that off. And then when you have that leakage under the skin, sometimes that can be a really tender area. So that's just a little bit about IV catheters, and I hope that answers any questions. If you have any other questions about IV catheters, please let us know, and I'll try and answer those too.